Thank you. I have a little tweaked my headlines. So, see, when it comes to lupus, in contrast to what Dr. Dharmanand spoke, see, we have at least only one organ to start with, and the other organs develop in the later course of the disease, rheumatoid arthritis. But when it comes to rheumatoid arthritis, SLE, systemic lupus erythematosus, it's a multi-system disease. It has a very broad spectra in its manifestations. It can be a simple skin disease to a multiple organ involvement at the simultaneous points. And I can say, it's often said that if you know about lupus clinical manifestation, you know 50% of the medicine. So that's being the case. SLE cannot have a single protocol or a single specific protocol. And as you know, no organ could have been spared by the SLE being affected. So it can almost affect every other alternate organ in a given patient or maybe in a different patients. So how do we decide, how do we take a call about the treatment aspects with reference to systemic lupus erythematosus? It depends on, first step, organ involved. As most of you know, when we start thinking about the lupus, we call it renal lupus or a non-renal lupus, whether kidney is involved or not involved. That's a broad division that happens when the decision to treat starts with reference to SLE. Then the next question that we always have to work with is how early we have diagnosed. Is the disease a long-running disease? Has organ been partially damaged? Or what extent the disease has gone through? And how appropriate treatment was initiated? Did this patient, though had a lupus of few decades, was he on a regular treatment? Was he in an appropriate treatment? Or was he not at all on a treatment relatable to lupus? So these are the conditions which decides, or which gives you an outline when we start managing the systemic lupus erythematosus. So as I said, precisely in contrast to rheumatoid arthritis, it's a disease with a large spectrum. The spectrum is too wide. It can be a simple skin disease to a complex disease of both kidney and the central nervous system being simultaneously affected. So as Dr. Dharmanand was saying, we are a little more ambitious as the time progresses because now we have multiple options to treat. We have a treatment which was simple hydroxychloroquine to a multiple biologics which are available even to manage the systemic lupus erythematosus. Now we are looking at what we call as a clinical remission, wherein patient of a lupus do not have a persisting ongoing activities. So we have different measures to measure the systemic lupus erythematosus. Being a complex disease, we have one simple scoring system called SLEDAI score. There is one more complex scoring system called BILAG score. The SLEDAI score looks into the 4 weeks, whether it is having an activity or doesn't have an activity. Based on that, it goes on giving a score. Whereas it comes to BILAG, it takes a call of whether it was there 4 weeks before, did it improve, did it worsen. I mean, I can say that even with 10 years of working with BILAG, even I get a back from the clinical trials that this BILAG is not scored properly because there is a queries, questions which comes from the central team which monitors the BILAG scoring that it should have been tweaked like that, it should have been done like that. So it's a little complex scoring system we have. But whatever the scoring system is, what we look forward in the current line of treatment is a sort of a good remission state where we wanted a complete control of the disease process where measure of the disease activity is minimal. So as we start progressing with the clinical remission, though we use steroids, we would like to stop the steroids and also over a period of time to reduce the immunosuppression that is there. So we start with a good treatment, get the SLEDAI score to the lowest possible, where we call it as SLEDAI score below 4 or is as close to 0. When it comes to 0, we call it as a complete remission with steroids, slowly get out of the steroids and then even slowly reduce the immunosuppression. So this is a possibility that has come over the last 2-3 decades. We can really work to get a patient of a systemic lupus erythematosus into a state of clinical remission, getting out of glucocorticoids, even getting out of immunosuppression. So the disease approach, in contrast to the rheumatoid arthritis, has a graded approach. We usually grade the systemic lupus erythematosus as a mild, moderate and severe. Number one, the base of the organ involvement. If there is a renal and central nervous system involvement, we usually call it as a severe disease. If it is skin and musculoskeletal system, it is a mild disease. Serosal and hematological and to some extent pulmonary involvement, they come under moderate disease. Involvement of any organ to the extreme right is usually a severe disease. Along with that, you may have a plus or minus of the milder manifestations. So as you move towards the right, the disease becomes more and more aggressive. So how does the scoring looks at it? See, scoring do look at it so that the scoring also will help us to say whether it is mild, moderate and severe. Any disease above 12 of a SLEDAI score is considered as severe disease. So that being the scenario, you can see the central nervous system manifestation, seizure, psychosis, organic bile syndrome, visual disturbance, cranial lupus headaches get a score of 8. Even if the two symptoms are there, the score bounds to 16. If you move towards the renal, it is the next organ in the scoring. It comes as 4. Every manifestation of the renal, urinary cast, hematuria, proteinuria and pyuria are scored 4. Any two manifestations, it scores by 8. When you go to the other features like musculoskeletal system, exception is vasculitis, which is little aggressive. Arthritis, myositis only gets a score of 4. And so also the few other manifestations like skin, new rash, alopecia, mucosal ulcers only scores 2, and the pleural pericardial only scores 2, and the other clinical features are scored 2 and 1. So even the score, to some extent, when you use SLEDAI score, helps you to grade the SLE, whether to mild, moderate and severe. But if you can see that it is the organ involvement which determines whether the disease is severe or mild or moderate. So here how even the scoring system has been patronized to get this gradation between mild, moderate and severe. So why do you need to grade this? Unlike rheumatoid arthritis, where we still work on a stepwise pattern, exception is when it is moderate, aggressive, whether there is a comorbidity or extra-articular manifestation, where we suggest a deviation from the normal protocol. Here, the protocol or the recommendation itself says the grade it into mild, moderate and severe. The first line of treatment keeps shifting from a milder immunosuppression to a more aggressive immunosuppression. So if it is a mild disease, you can fairly well do with hydroxychloroquine, methotrexate, or to some extent azathioprine, a moderate dose of MMF to intense dose of mycophenolate, and so also the cyclophosphamide and rituximab, we restrict it to the severe disease of systemic lupus erythematosus. This is, as a first class I said, we class them as non-renal systemic lupus erythematosus, and when it comes to the other group, the lupus nephritis, here we more depend on the type of the renal biopsy, whether it is 1 and 2, usually we go with a milder initial manifestation, milder dosage, or if it is the 3 and 4, we go with an aggressive. Again in 5, we little step down because the histological pattern have milder approach, moderate to severe aggressive disease. Based on that, we initiate. And here when we treat lupus nephritis, we initiate with an induction followed by maintenance. Either you use cyclophosphamide, mycophenolate or rituximab to induce a disease regression followed by a maintenance therapy for a longer time till you achieve a remission. All throughout we keep either the hydroxychloroquine as a part and parcel of the entire treatment regimen. One of the major issue that comes for us is when a patient has a milder symptoms, when he has only a little of proteinuria where you can score 4, and patient has a skin of a malar rash, it comes to 6. Whether I consider it as a moderate disease or an aggressive disease, or down the lane as he moves into get into an aggressive disease, where we should have thought of giving him a little aggressive disease in the very beginning, which could have averted the progress of the disease to a moderate to severe disease. It's one of the major dilemma that we are facing with reference to the systemic lupus erythematosus management. Usually the score and the classification, which is most of the time organ based, will only let us to score when the organ is affected. It is like wait for the fire to be blazed out and then only you think about putting down the fire. That's not the current approach what all of us are thinking about. We think about early identification and prevention of the possible complications or the other issues that can happen. So that's where we are now caught up with reference to systemic lupus erythematosus. I think my previous speaker, Dr. Dharmanand, said we were trying now to go for a prevention of development of rheumatoid arthritis. In lupus, we are not thinking that far because we have not gone even up to identifying in the very early course of the disease who is likely to become an aggressive and who are likely to maintain a moderate disease. In our experience, I think most of the rheumatologists do share that some patients which looks very aggressive may remain the same for next 10 years, 15 years with a simple dose of hydroxychloroquine and azathioprine. Whereas a patient who is on a very aggressive disease continues to have a very aggressive disease. And his aggression is so bad that you would have, in spite of pushing so many drugs, you may not get the benefit. And sometimes a thought back to say that if I had have used this aggressive disease or a treatment when he was milder, could I have achieved a better outcome to this group of patients. So to work on that, we were trying a lot of other complex mix and match processes. We tried to cluster the patients. This is all across the globe, the things are working. When we tried to cluster the patients, we could see that some of the manifestations do suggest that the disease could become more aggressive down the lane. Suppose early renal involvement of certain of the skin manifestations, involvement of certain of the other features, and even the presence of few of the autoantibodies do help us in predicting the progression of the disease, but still the process is in its beginning. Hopefully, if we are able to get the sort of a composite score of the organ involved versus the autoantibody profile plus the other clinical features and other laboratory features should help us to pick and choose the best patients who may need an aggressive treatment. However, the current management still goes on the organ that is involved. The clinical organ involvement is the one which determines that. So in a nutshell, lupus is not a single disease as we look at it. It's a mixed bag of different clinical manifestations, and the current approach is still organ based if it is skin and the musculoskeletal. The treatment line is different from the renal involvement. The treatment line is little different from when it is pleural and other clinical manifestations. Most of the drugs are tailor-made to that, and hopefully down the time we should be able to get some sort of a model which can assist in identifying the rapid progressor and also predictably of what organs will be affected down the lane. Hopefully next 5-6 years we should be in such a place where we would be able to pick and choose the right patients for the right treatment lines. Thank you very much.